Thank you for joining us today. My name is Carol DeAndres, and I am the Stakeholder and Public Engagement Manager on the Master Plan for Aging team here at the California Department of Aging. And happy to welcome you to our first meeting of 2024 of the California Aging and Disability Research Partnership, CADRP, C-A-D-R-P, CADRP for short. And today is January 19th, 2024. And we are still saying Happy New Year, everyone. I'm going to go over a few logistics. So let's move to the next slide, please. Thank you. There we go. Live captioning and American Sign Language is available. The live captioning is through the webinar function. Meeting slides and the transcripts and the recording will be posted to the CalHHS Master Plan for Aging website after the meeting. And committee members, if you haven't already, could you please update your name display in Zoom by, this would be the committee members and panelists or presenters, guests. Please update your name display in Zoom by clicking in the upper right-hand corner of your video and selecting rename so we can know who's joined us today. Next slide, Rosie. We do have a few meeting operations we would like you to be aware. The chat function is enabled for committee members and panelists and Department of Aging staff to share meeting-related information and resources with attendees. The public is able to view the chat during the meeting. The chat and the question and answer functions are not enabled for comments or questions from public attendees, but we do invite you to participate in the public comment period at the end of the meeting. And of course, you can provide your written comments at any time to our Engage email box, which is engage, E-N-G-A-G-E at aging.ca.gov. Next slide. Just logistics on the public comment operation. Attendees joining by phone, press *9 and your line will be highlighted and we'll unmute you. Attendees by the Zoom webinar, raise your hand and we will announce the last 4 digits of your phone number and unmute your line. And just a reminder, public commenters will have 2 minutes. And again, anytime written comments can be sent to our Engage email box, engage@aging.ca.gov. Next slide. Wanted to talk about the purpose of this stakeholder meeting. The primary purpose of the California Aging and Disability Research Partnership is to advance age and disability-focused research to strengthen the evidence base for promoting equitable opportunities for Californians to thrive as they age. Number 2, to provide input on key performance indicators and data sources to inform MPA outcomes reports and the data dashboard for aging. And finally, model a research partnership between California state government and academic institutions focused on using data for action and equity that can be replicated across other CalHHS person-centered, data-driven priorities. That is the committee purpose. And of course, we couldn't do this without our committee members. And as you can see, we have a very esteemed panel of researchers from academia, private sector, nonprofit, philanthropic. We are very fortunate. We thank you so much for joining us. We thank you so much for your hard work to help inform the Master Plan for Aging. And so with that, I will turn it over to Susan DeMorris to welcome us. So Susan, hold on, let me spotlight you. Here we go. Good morning, Susan.
Good morning, Carol, and good morning to everyone joining today, panelist or other, if you're not a panelist and you're using a panelist link, or if you're all are welcome here today. It's great to be with you for the first meeting of our calendar year. And I was thinking of that old adage about the month of March. It roars in like a lion and out like a lamb. January has definitely roared in like a lion for all of us working on the master plan for aging. It started on January 10th with the governor's proposed budget for the 2024-2025 fiscal year, which overall programs supporting older adults, people with disabilities, and family caregivers fared exceedingly well in light of the state's budget deficit. Very soon after, we launched the LGBTQIA+ statewide survey. Congratulations to all of you who had a hand in that, and Ross and his team. You'll hear more about that on today's agenda, but we're really excited to have that now out in the community, and we need your help promoting it. We also did some work last year with the state's Little Hoover Commission. They held 2 oversight hearings on the master plan for aging, and they released their first report and recommendations earlier this week. So we'll share that with you in the link. And there is one particular recommendation around data that I think would be of interest to this partnership. We also this week released our findings from the California 2030 stakeholder engagement over the past year, a really focused quantitative and qualitative research endeavor to put a bright spotlight on the network of area agencies on aging in our state. We'll share that report with you, and we're eager to get going on the recommendations to strengthen that network before the year 2030, when, as we all know, 1 in 4 Californians will be 60 or older, but perhaps more significantly, about 2 million Californians will be 75 or older. And we really need a system that can support more medical complexity, people who have depleted their income and assets, more behavioral health challenges, more precarious housing, and a higher number of people who will be living alone if they outlive their family supports. And then last but not least, next week we will release the 3rd annual Master Plan for Aging report to the legislature. So this is part of our statutory requirement to provide an update annually to the legislature. We're excited to get that out next week in conjunction with the Master Plan for Aging Impact Committee. So we'll be sure that you all see that. And those are just a few things happening this week at CDII across the Health and Human Services Agency and with our Master Plan for Aging team. I'll turn it back to Ross, and I'm excited to listen and learn more today from all of you. Thank you.
Thank you, Susan. So much going on. Good morning, everyone. Ross Lallian. I'm the Chief of Research with the Department of Aging. Thank you for your time today. I'm really excited for this discussion. A lot of important agenda items today. So the first agenda item is related to the state's healthcare payments data program. So I'd like to introduce Mike Valley, and Mike is the Deputy Director of Information Services at the Department of Healthcare Access and Information. So Mike will present on this program, and we should have time at the end for Q&A. So with that, I'm going to hand it over to Mike.
All right, thank you, Ross and Director. It's great to be here. I'll also indulge in saying Happy New Year to you all. Again, Michael Valley, I'm Deputy Director for Information Services at the California Department of Healthcare Access and Information, and happy to be providing a presentation today of California's all-payer claims database, the healthcare payments database. And I'm sharing my screen now, so please do let me know if you have any issues in seeing it.
Looks great, Mike.
Thank you. So as you may know, our department has a long history as a health data organization supporting informed decisions in the state. For nearly 50 years, we were known as the Office of Statewide Health Planning and Development. And in July of 2021, we graduated from an office to a department, the Department of Healthcare Access and Information, or HCAI, H-C-A-I. This change was additive. We've expanded our portfolio of programs and services and doubled down on our mission to expand equitable access to healthcare for all Californians, one of 13 state government departments under Health and Human Services, and a proud sibling department to the Department of Aging. But we have a unique role in supporting the healthcare delivery system with a deep commitment to data, research, and transparency. On the slide is a description of the various healthcare data and transparency programs HCI oversees. HCI administers California's hospital discharge database and has since the 1980s, which collates over 15 million records annually of inpatient discharges and emergency department encounters. We perform outcome studies for cardiovascular procedures like heart bypass surgery. HCI has been collecting and making available to the public detailed hospital financial disclosure statements since the 1970s. In 2018, we started one of the first state prescription drug cost transparency programs in the nation, and we continue to publish new health workforce data as part of our Health Workforce Research Data Center, which uses provider licensure, health professions education, and other data to evaluate the supply and demand for the health workforce in California. In 2023, we published over 50 discrete data sets as well as 60 online visualizations and interactive reports for public use. We recently published information on behavioral health, related emergency department encounters, social drivers of health in preventable hospitalizations. And then of interest, potentially, we recently published a report on hospital discharges to hospice, both home and facility, showing there were over 55,000 such discharges in both settings in the state in 2022 alone. Many more as well. You can visit hcai.ca.gov/visualizations to see our most recent and featured product releases. This is de-identified public information for each interactive report. We also publish the underlying open data in machine readable, API-enabled formats with robust documentation about the data to support its accessibility. Last year, we also fulfilled over 200 requests for non-public data. We release research-level identifiable files to academics and other qualified entities, including state agencies and local health departments. And so we're proud of the significant contribution that this data and this department's work has had to the body of knowledge for health policy and practice over decades. With that, I'd like to now highlight the healthcare payments database, California's all-payer claims database. This is our newest data offering, the only all-payer state-run claims database in California. We call it healthcare payments to reflect the prevalence of managed care and value-based payment in the state. 20 other states have all-payer claims databases, but this has been a long time coming. State policymakers, so many others have been working since at least 2007 to establish a state all-payer claims database in California. So we're standing on the shoulders of giants and learning from others and the many claims data warehousing efforts that have come before us. In 2018, HCI received the initial startup funding to begin studying and planning for how to build the database. And in 2020, the additional enabling authority to establish the database was granted. Since that time, we've been heads down, building our team, working with data suppliers and other stakeholders, and engineering the technology infrastructure that supports this database. And I'm proud to say that we now have a 4-year historical starter data set loaded into this database with over 5 billion claims, 17 billion total records. Certainly the single largest data aggregation undertaking in this department's near 50-year history. And we are now successfully collecting and processing over 100 million new healthcare claims and encounters each month. So that number is just going to keep growing as we add years of data to this database. HCI historically worked with the hospital sector, and so we're just so proud and happy to be engaging with new partners, health plans, and others, learning about issues of insurance coverage and affordability, and diving deeper into the claims data to grow our knowledge and expertise. As mentioned, the HPD collects data from all payers. There are some limitations to this. The uninsured, self-insured, self-pay, VA, those are not included in the database. We're closely monitoring issues of data quality and completeness. And on March 1st, we'll be issuing a report to the legislature that overviews the data quality in the database, but we expect for that to continue to improve over time as we work with the data, work with partners, our expertise builds, and the database matures. We've adopted a national standard for claims and encounter data, which includes common information used for billing, such as the patient's diagnosis, the procedure performed, the amount paid for a claim. That standard was ratified by our stakeholder advisory committee in 2020. And we're very fortunate to have a close relationship with the National Association of Health Data Organizations, which oversees the National All-Payer Claims Database, common data layout, format, and members of my team sit on the board of directors for that organization. I also just want to say how thankful I am to California's health plans and insurers. They've been fantastic partners in this effort, supplying quality and timely data according to HCI's requirements. And I could say that without their partnership, the progress that has been made on this effort to date would not be possible. And then a special shout out to the California Department of Healthcare Services, who supplies all Medi-Cal data, both fee for service and for Medi-Cal managed care plans. Database is intended to be used by a wide variety of audiences, public and private. How can we collectively all in implement policies that can improve our healthcare system? You'll see the program's goals here on the screen. These are enumerated in California Health and Safety Code as well, and further adopted by our stakeholder advisory committee. There are two governing bodies that administer the HPD. I mentioned the advisory committee. This is the policy level group that advises HCI on program policy. It's a cross-sector group of payers, providers, researchers, consumers, and others. They meet quarterly and have been since 2020. We're also overseen by a data release committee. This is also a cross-sector group, including technical experts, and whose role is to review requests for access to non-public data. And I'll share a little bit more about their role in a moment. On the screen are principles that HPD's public committees have adopted to guide the department on the use of HPD data. All of them are important. I'll highlight two. Item number one, just so important to protect patient privacy. It's a pillar in everything that we do at HCI with data. And then item number two, the use of the data should be feasible and credible with the available data and resources. Also a key pillar, evaluating the appropriateness for the data to answer any particular research or policy question. And this is critical, we think, to maintain the public's trust in the database and the information that comes from it. How can you use HPD data? So far, we have released 2 public analytical reports from the HPD, and we will continue to release new reports ongoing. In October, HPD's advisory committee provided input on public reporting priorities for 2024 and what healthcare topics we should study next with the data. And additionally, just as we have a data release program for our hospital data, and as mentioned, we're in the process of designing such a program for the claims data. This program will have a greater pool of eligible data recipients. So beyond researchers and hospitals, health plans, provider groups, and others will also be able to request record level data from the HPD. This program is expected to begin accepting requests in Q2 of 2024. And we're meeting regularly with the Data Release Committee to co-design this process, including designing the data extracts and products that will be available at the record level for requests, how this group will work with requesters to review their requests, as well as the pricing for access to the data. All are welcome to participate in those public meetings, and more information is available on our website. I mentioned the public reports. Each of these reports has hundreds of thousands of rows of data available. The underlying de-identified information is downloadable, machine readable, and API enabled. I heard someone say to me, Mike, we could spend our whole career just using these 2 data sets that you've already published. There's so much information there, but we also know there's so much more that could be done too. I'll just briefly give you an overview of the 2 that have been published so far. The HPD snapshot, hpd.ca.gov, /snapshot. The purpose of this product is to provide an overview of what data is available in the HPD system. So if you add it up, again, over 5 billion claims and encounters over a 4-year period. You can also see the number of covered lives by payer and line of business. We're working on getting more granular with these, looking at the dual eligible population and other more detailed geographies. You can view by month the number of services received by claim or encounter. We also have 2 views for the top medical procedures and the top drug procedures by number of claims submitted. So we think this is a really foundational product and report for users to get familiar with what information is available in the database. Second, HPD measures, hchi.ca.gov/measures. There are 4 distinct views in this report presenting standardized measures on chronic conditions, demographics, and utilization. Further with filters by up to 23 individual measure categories, and the ability to do simultaneous groupings by dimensions such as age, county, sex, payer, and reporting year, and with the ability to compare to statewide averages. We included several starting prompts on the webpage for this report to demonstrate what you can do with this information. So for example, answering the question, what percentage of Californians in my age group have a diabetes diagnosis? And you can answer that question. Is the number of surgical inpatient stays increasing or decreasing over time? We recently presented this report to the Coalition of Local Health Officers in California, and there was a tremendous amount of interest, and we're very excited to have this initial product be published on our website, and we'll continue to refine it and improve it over time. Our next public report will be released soon, and that'll be based on prescription drug costs. We're workshopping the design of that report now. It's our first look at cost information in the healthcare payments database, so there's a tremendous amount of interest and anticipation, and we're very, very excited. Expect that to be released in Q1, and you can sign up for our listserv to be alerted just as soon as that report is published. At the October 2023 advisory committee meeting I mentioned, our advisory body recommended 3 priority topics that HCI should focus on in 2024 for our next round of reporting. The first is social drivers of health and health equity. We're looking at the Healthy Places Index and other place-based proxies to fill in some of the gaps in the patient demographic data that we have in the database. That's number 1. Number 2, I mentioned our prescription drug report. The initial report will be published soon. We want to further enhance that report with more data elements and more cost categories. And then finally, our next foray into healthcare costs, looking at hospital spending, and certainly a known driver of cost of care, and something that was of significant interest to our stakeholder group. Finally, we'll plan to refresh the snapshot and measures product with new years of data and look at ways that we can enhance those products. So we're very, very excited, again, about all the public reporting opportunities that this database can provide, and we're really just getting started, I think, with what will be possible. As I mentioned, we're also in the process of designing access to non-public data, and I wanted to introduce a foundational concept to that process for HCI and for the HPD, and that's the concept of a secure data enclave, which is described on the screen and which we're in the process of testing now. Our statute contemplates that this approach to providing virtual access to data, where the data remains on HCI servers but can be viewed and analyzed through a remote desktop, is the best way to preserve patient privacy. And so we're committed to doing that. It aligns with our values. The technology resources are there to support it. So I wanted to introduce this concept. I'm happy to answer questions if you have them. Though our statute does permit transmitting data outside of the database environment, the bar will be very high to do that, and our data release committee must approve any such instance. In terms of the process itself, for those familiar with an institutional review board, this is somewhat similar. The process will start with a request to the department for data. Again, we expect to open that process in Q2 of this year. A good way to begin might be to look at the public reports we have published to get a feel for what the database is capable of to help scope your research question. Those requests will then be triaged by HCI staff and routed to the Data Release Committee for their recommendation at their public meetings. Additionally, the Department of Healthcare Services will need to review any requests that include Medicaid data. And the CalHHS Committee for the Protection of Human Subjects will also need to review for research projects that request access to direct identifiers. HIPAA limited data sets will also be available that omit identifiable data elements, and those will have a somewhat different process and bar to access. I mentioned the Data Release Committee. I just wanted to show their names on the screen. This is a tremendously esteemed group. You may know some of them well. I could say Dr. Terry Hill is very keen on addressing issues of aging and working in the gerontology space and supporting the aging community. And we're very fortunate to have him as a member of our group. But these are the folks leading the charge, designing the policies and procedures for data release. They'll be the ones voting on recommendations to release data. And again, just very thankful for the service that all of these individuals are providing to the department and the state of California. In closing, I'll say thank you for your interest in HCI and working with us to advance evidence-based care in California. There are some links on the screen for how you can continue to engage with us. I will draw your attention to the second to last bullet there. We are currently in a public comment phase for the regulations that govern our data release program. I can say that overall, these are meant to provide structure, but also be flexible so that the department and the committee can gain experience over the next year in processing those requests. Anyone is able to submit comment, and the last day to do so is February 1st. So with that, again, I'll say thank you. I'm happy to take any questions that you may have. Thank you.
Thank you, Mike. So I think for the panel members, we have time for a few questions. Awesome presentation, very comprehensive. Really appreciate it. And I could help with raise hands and any questions that come up. So please feel free. Bella, go ahead. I see your hand up.
Yeah, I hate to say it, more of a comment than a question. Thank you so much for such a terrific presentation, and just, the availability of these data is going to be so transformative for, health and policy research in California. And I especially appreciated your emphasis on data privacy and security. And I really appreciate the incredible thoughtfulness that's gone into both making data available so we can do rigorous policy and health research, and making sure that the data is incredibly protected. So we are very excited to be applying for these data early this year, and really looking forward to doing some transformative research. So
Thank you, Bella. Anyone else?
Can I go, Ross?
Absolutely.
Yeah.
Go ahead, Zia.
I will echo everything that Bella said. Michael, this is a wonderful resource that you're building for both the academic but other communities. As I was looking at the data sets available, would it be possible to differentiate the fee-for-service versus the duals versus the MA plan patients through this data?
Fantastic question. I think short answer is yes. We are collecting encounters for non-claims based payment arrangements as well. However, we're lacking the actual payment information. As you can imagine, there's some complexity there in the non-fee-for-service world, but we're very excited for how researchers can start to dissect that. There's proxies and other ways you can approximate payment for non-claims encounters, but then we'll also have all the fee-for-service information. So that's something to look at. And we are in the process, it's a multi-year process of adding submission of non-claims-based payment information from health plans. So we're sort of first in the nation. We're, again, engaging with our partners at the National Association of Health Data Organizations to develop a national specification for that. But that's something that will be going through the public comment period soon. And we expect that in 2025, we'll be filling in the non-claims payment information with the fee-for-service claims and encounters that we have now. So a lot to sort of unpack there, but we're really excited to see what can be done with these data.
Thank you so much.
Thank you, Mike. I don't see any of their hands, so kind of a last call for Mike. If not, thank you so much, Mike. That was very informative. Appreciate your time.
Thank you so much.
Okay, take care. Have a good day, Mike. All right, so we can move on to the next agenda item, and I'm on deck for that, and that is around our master plan for aging key outcome measures and a discussion around that. So I'm going to try to share my screen. Give me 1 sec here. Can everyone see my screen? Should be a slide deck.
Looks
Okay.
great, Ross.
Okay, great. All right, so I wanted to start off this discussion with kind of grounding ourselves on the 4 outcome measures that we landed on. So the first one's around reducing homelessness for older adults, reducing self-reported psychological distress among older adults and people with disabilities, reducing burdens faced by family and friends caregivers, then increasing the provider to population ratio among the direct care workforce. And I want to give a thank you to the work groups who have volunteered their time over the last several months. There's many of you on this call. And this to talk about data sources and kind of keep moving this process forward. So thank you. It's been extremely helpful, and I look forward to collaborating with you in the coming months to flesh these out even further. And so I'm going to provide updates on each of these measures, but I'm also going to share an early draft of a dashboard related to each measure, because if you recall, our goal is to have visualizations and dashboards on these measures included on our data dashboard for aging, because we want to be transparent. We want you all and all of our stakeholders to have access to these data at your leisure. So that's a really important piece of this exercise. So I'm going to be kind of toggling back and forth between the PowerPoint slide deck and an interactive dashboard. And so we have 30 minutes for this agenda item, only have a handful of slides, so a lot of time for discussion. So I appreciate your feedback on the dashboards, comments, questions, etc. And the last piece before we move forward is an important piece of this exercise is equity. So we want to be able to measure as many equity-related variables as possible based on available data. And you'll see examples of those equity variables in the dashboards when we share those. So with that, we can hop into our first measure, and that's around homelessness. So we have a dashboard for your feedback today, and that dashboard is based on updated homeless data integration system data, or HDIS data. And so the work group, we feel as if this is the most comprehensive data set related to homelessness in the state. And our colleagues with the Business Consumer Services and Housing Agency, they've been phenomenal partners, and they supplied these data to us. And just some context on these data, the years of the data are from 2017 to 2023. These data are reported to the state via continuums of care, or COCs. And COCs are homeless service coordination and planning bodies. There's 44 throughout the state. So we do have statewide data. The variables include age, ethnicity, race, and gender. About a third of these rows are masked, but we work closely with our colleagues at BCSH who supplied these data to get that number down as low as possible. But some of the groups that are masked are groups that are masked with many data sets that we work with, probably you as well. So for example, Native Hawaiian or Pacific Islander populations, that's masked at about 2/3. Asians or Asian Americans, that's also masked at about 2/3 as a couple examples. So this graphic here, this comes from the Business Consumer Services and Housing website and displays the data reporting process. And essentially how this works, I thought this would be helpful context. Folks at the local level who actually provide services, they provide data in the homeless management information system. And that's how the state receives these data. And the services are related to emergency sheltering, rapid rehousing, permanent housing solutions, outreach, prevention, et cetera. And so the state works with the COCs to collect these data on a quarterly basis via a secure file transfer, and then the data standardized claims and is ready for analysis. And so that's how the data comes into us. And with these data, we're able to create the following dashboard, which I'm going to pull up. So I'm going to pull up this dashboard. Hopefully there's no technical issues. I'm always a little nervous sharing a live dashboard. Can everyone see the dashboard?
Yes.
Okay, good. 1 sec here. Okay. And so I just want to, is this large enough? Let me blow it up a little bit. Let me know if it needs to be larger. But the indicator, how we're measuring this measure, is we're looking at the number of persons age 65 and over experiencing homelessness per 100,000. So this is a rate. And something that the work group informed us is maybe we should lower the age threshold from 65 to 55. Can you hear me, Steve?
I think maybe he's saying move it up a little bit or
Move it up. Oh, okay.
Yeah, the window. We only see half of California to about
Okay, no, but
Obispo.
right. Okay. No, thank you for that. Let's focus on this top ribbon, then I'll scroll down. So So sorry, the measure that we're using here is measuring our rate of older adults experiencing homelessness. Currently is 65 plus, but the work group recommended maybe lowering that threshold age down to 55. So love to hear your feedback there. And then we have baseline data. And so it's 126. Basically what that's saying is in 2017, 126 older adults out of 100,000 are experiencing homelessness. In our most recent year in 2022, that number's increased a lot. Unfortunately, is 283 now. And that's what's driving the status bar, which says getting worse. We're comparing the baseline data to the most current data. And that this line graph also displays the data year over year, and it's showing an increase by year, unfortunately. So that's what's driving the status bar, and you'll see these on all four of the dashboards I'll share today. And then a really important piece of this exercise is target setting. And so this is a critical next step for the work groups and the partnership to really think about what targets we want to set going forward to 2030, what do we want to meet. Right now it's TBD, but hopefully at the next CADR meeting in May, we'll have something there for you to react to. So that's kind of the top ribbon. And then I want to focus on this equity index. This is a really important piece, this exercise as well. And so the equity index measures variation between populations. And the scale is 0 to 100. Basically, the lower the number, the more equity there possibly is, the higher number, the less equity there is. And I'm going to hover over one of these bars here to provide some context of what I mean there. So for race, for example, the equity index score is only 18. That's pretty low out of 100. And so if you hover over the bar, a tooltip pops up, provides more context. The reason that score is so low is because Black or African-American Californians, older adults, experience homelessness at much higher rates relative to other racial groups. And so you have that detail when you hover over the bars, and that's what's driving this equity score low. If we look at gender, the score is only 39. That's also pretty low, and that's because males have higher rates of homelessness compared to females and other genders as well. For ethnicity, the equity score is high, it's 97. And if you hover over that, we're not saying that this rate's good, but the rate's similar, right, for Hispanic Latinx versus not Hispanic Latinx. So when I open up for questions here, I would love to hear your feedback about this equity index. Is it helpful? What can we do to make it more helpful or more user-friendly, et cetera? Then we have the maps. We have variation by geography, and these geographies are based on those continuums of cares. So if you hover over the respective COCs, you see the rate for that respective COC. Something that kind of caught my attention, at least, was in Northern California, Mendocino, in Humboldt, the rates were higher relative to other COCs. Of course, there's less older adults in those regions versus Los Angeles, for example. Those rates are relatively higher. And then something else that's really critical, I'd love to get your feedback on, is potential drivers of homelessness. So that's a really important piece of this exercise as well, and the work groups discussed that quite a bit. What's driving these issues? And so we have a couple examples here. We have income, and that's average income per older adult. We have poverty, and that's based on the 100% FPL or federal poverty level. And then we have housing cost burden, and that's based on older adults who rent and spend more than 30% of their income on rent. But I'd love to hear from you. Are we missing anything? What else should we be tracking? Should we replace anything as a driver as we develop this dashboard? And just other comments and feedback in general on the equity index or anything else. And so I'm going to share 4 of these dashboards. I'm going to pause after each one just to open up for questions and feedback. So anyways, I'm going to pause there, and I'd love to hear some feedback from the group. And Carol, if you could help me with hands because I'm sharing screen, I would appreciate that.
Not seeing, here we have a hand up.
Elizabeth, yeah.
Okay.
Hi, good morning. I love this, Ross. It's so cool to see this and so connected to work that we're doing over in CDII. And it's just great to be able to have these visuals like right off the bat with the deep dives. I'm curious about the equity metrics, and I'm curious if the numbers that are shown there are just the regular counts, or if they're normalized or adjusted to reflect the proportion of the population as well. So I think that if they are just counts, that the equity gap might be even bigger than it seems.
Oh, yeah. So I think it's adjusted for a proportion of population. And Evan, sorry to put you on the spot. My colleague Evan Wallace helped develop these visuals. If you have any feedback, Evan, you could pop in or place in the chat. But it is based on the proportion of the population. So for African Americans, for example, they only represent about 6% of the state population. So it's alarming to see their you know, the overwhelming kind of the ratio of the rate so high. And that's what's driving that number lower. Really good question. If it was just counts, it wouldn't capture it as accurately, right? So appreciate that. Anyone else in the housing and homelessness work group? We had a really good conversation a few weeks ago about this, and if you want to share some of your thoughts with the larger partnership, I think that would be helpful as well. Go ahead, Bella. Thank you.
No, just wanted to express appreciation for all the work that's gone into these measures. And, you know, something we really have been giving a lot of thought and discussion to is, number one, are we measuring the right thing? You know, is it rigorous? And what data sources do we need in order to really deeply understand what's going on in California and evaluate interventions? And so I think this is a really great public facing, you know, sort of portal where people can really look and kind of see where we are. I personally love these. I think that they're thoughtful and well done. And we really look forward to making quite a bit of progress this year in kind of digging in and really trying to understand, you know, how are the interventions that California is doing working.
Thanks, Bella. I guess a question for the partnership for me is, oh, go ahead, Jasmine. I see your hand up. Thank you.
Oh, no, go ahead. Respond to that. I'll be shifting.
Okay, I was gonna ask about drivers. Just curious what the partnership thinks about these drivers that we currently have on the dashboard. Are we missing? Should we replace any of these drivers? So I was curious about those thoughts there, but go ahead, Jasmine. I'll hand it over to you.
Yeah, I just had a question about the age range that you had mentioned, lowering it to 55 years old versus 65, and what factors went into deciding that, since we know that especially with the profile of older adults who are experiencing homelessness, you know, a lot of them don't reach those older ages or higher, older ages, and the ways that older adults are beginning to experience homelessness are pretty different than those who have been chronically homeless at a younger age.
Great question. So we started with this. 65 was kind of our first draft, this initial draft, and then the work group, you know, talked about 55 possibly. And the way that the data is age bands at 10 years, it's 10-year age bands, but it's at the 5, so it's 45 to 55, 55 to 65, etc. And so we discussed 55 as maybe the definition for older adults for the homeless population, as you mentioned. Unfortunately, a lot of them don't make it beyond 65, right? So another option could be lowering even to 45. So the reason we kind of thought about 55, just the actual data is presented that way because it's by the 5s. Does that make sense? Thanks.
And Ross, the only thing I will add to that is that, you know, from a biological versus chronological age, a lot of this population has the same needs at age 55 that you would see in a 65, 75-year-old.
Right.
Just because of their life circumstance and all the other issues.
Okay. Do you think 55 is the appropriate age, or even going lower, maybe to 45?
I would suggest perhaps it should even be data driven, that at the point we're able to obtain data, to look at, I mean, sometimes there's, you know, just a steady slope, and sometimes there's sort of these break points where you see a real escalation in, you know, rates of disability, rates of homelessness, things like that. And so perhaps one potential approach could be, once data are available, we can really look at what ages do we see a steep rise in either disability or homelessness.
Okay, I like that. Thanks, Bella. Does a partnership have thoughts on these drivers? I feel like that's a really important piece of this exercise. We want to be able to display drivers that make sense, that we're able to track and provide value. So are these the right drivers for this initial cut? Is there anything that we're missing? Go ahead, Catherine.
Hi, these are great data and great presentation. Thank you. I'm looking at the drivers, and I think they're all really clearly relevant to factors that may drive homelessness. A couple other thoughts come to mind. I'm just wondering how practical it would be to get measurements on this, and they're interrelated. So employment opportunities, and of course, that would likely intertwine with income and poverty, but also social network, the extent to which the older adult has family, friends, and looking at the higher risk among those who maybe don't have those connections. Again, where those data might come from might be even more complicated than getting the employment figures. But given that the employment is increasingly important for older adults, especially low-income older adults, in order to thrive and to remain housed, I'm curious about if the committee might have looked a little bit at that factor, potential driver.
Thanks, Catherine. We haven't looked at that yet, but that's a really good idea and thought, so we could look into that. Appreciate it. Go ahead, Donna. I see your hand up.
I just want to, another potential driver that we find is becoming a family caregiver and people dropping out of the job market, and then also not having housing because they've moved in with their relative, and when the relative passes away, they have nowhere to go and they haven't been employed in many years. So I don't know how we can look at that, but you'll read stories after stories and you'll say, it all started when they had to take care of this person.
Okay. Thank you, Donna. Thank you. Steve or Bella, I don't know who went first,
Yeah.
So go ahead, Steve. I see your hand first.
Okay. I like that, though I think we're going to have to learn how to get more sophisticated to gather that. But I was wondering also if it would make sense to sort of drill down in a couple of counties to see, while these are important drivers, the question might be availability of the services to meet those needs. And so I think maybe doing some more qualitative, ongoing, regular information in particular counties, and we should figure out which would be the good representative ones to get a fuller picture.
Good thought. Thanks. Go ahead, Bella.
Yeah, and so these sort of drivers are all particular to people, but probably, if not the single biggest driver of homelessness, is the availability of housing overall, and then in particular, the availability of subsidized housing. So any models that we do would also have to incorporate that. They wouldn't necessarily have to be on this dashboard because that's something that's sort of true of any given county, but that's also definitely an incredibly important driver of homelessness.
Yeah, that's a really good point. Yeah. Thank you. Thanks for your feedback. I don't see any of their hands up, so we can move on to the next measure. So I'm going to put the slides back up. So next measure is around psychological distress. And so we have created a dashboard for your feedback today based on some of the data that we currently have on our data dashboard for aging, and that comes from the California Health Interview Survey, or AKA CHIS, and we pulled in some data from the Ask CHIS feature. We're also working with Catherine and the CHIS team to receive updated data, and some of the highlights of what we're asking for is on the slide. So I think a really important piece is adding moderate psychological distress, because currently we only have serious psychological distress, but adding moderate is important because folks bounce back and forth between moderate and serious psychological distress. That's a really important piece of the story. Adding a measure for disability, that's really important as well. So we currently don't have that. Hopefully with the next iteration of data, we'll have that as well. And so we can cross-tabulate with demographics. We have that feature currently available on our data dashboard for aging, and then also with age band. So we have a dashboard to react to today, but hopefully at our next meeting, it'll be even more robust. And so I'm going to share the dashboard for psychological distress. Can you guys see the dashboard? I think it's loading right now.
Looks good, Ross.
Good. Okay, it's working. The technology is working. So the measure for this is the percent of older adults, and we define that as 60 and over, that's self-reported psychological distress within the last year. The baseline number is 3.9% in 2017. The most recent data is 2022, and it's 5.4%. And that's why the status is getting worse. Of course, the target's TBD. And this line graph's interesting. I mean, you kind of know the story, right? We see the spike with COVID in 2020. It has gone down a little bit from 2021 to 2022. And we have more demographic data. So this equity index has more variables, as you can see, compared to the homelessness dashboard. So if we hover over age, for example, we see that serious psychological distress, folks in that 60 to 64 age group have the highest self-reported rate. Then it starts going down, especially when folks are over 70 years of age. It really does go down quite a bit. If we look at gender, the score is pretty low. It's a 52 for the equity index score. And that's because females report most double in terms of a higher rate of serious psychological distress. And then for sexual orientation, I just want to point that out. It looks like the LGBTQ community, relatively speaking, reports higher rates of serious psychological distress. So that's the equity index on this dashboard. And then for the variation by geography, we use CHIS county grouping. So CHIS groups some counties, some of the smaller counties, but it provides insights. We can see the regional variance. It looks like, I think Humboldt County has the highest rate at 11.1%. San Luis Obispo is only 3.3%, and Orange County is only at 3.4%. Then if you notice on the right-hand side, the potential drivers, kind of this blank canvas. The work group, we've talked about it quite a bit, but I'd love to hear from the partnership about what drivers should we add to the serious psychological distress dashboard? What should we be tracking? What would be helpful? And of course, any other feedback that you all have. So I'll pause there and open up for conversation. Olivia, go ahead. Welcome, Olivia, by the way. Olivia, new to the partnership, is your first meeting, so welcome.
Thank you. Thank you, Ross. I appreciate that. Yeah, I was just wanted to offer maybe social isolation or loneliness as a driver, potentially. Just wondering if that influences, whether someone is reporting more serious psychological distress or not.
That's a really good thought. Thank you, Olivia. Absolutely. I would think that would probably drive, that's a good driver for this, I think, so thanks. Steve, go ahead.
Yeah, I would also add, obviously, the same idea as before, the access and availability of services, of behavioral health services.
Great, thank you. That would probably vary by region as well, so that'd be interesting to map it out. Anyone else have thoughts? Okay, so we can move on to the next measure, and this is around burdens faced by family and friends caregivers. I'm gonna share the slide deck. So we have current data on our data dashboard for aging around this measure. It's a bit stale. It's from 2019 and 2020. But the burdens that are collected in this, let me back up for a second. These data are also from CHIS. And the CHIS questionnaire asks about financial stress, physical and mental health problem, or a change in job status based on caregiving. And in 2021 and 2022, the CHIS questionnaire focused more on supply. It asked folks if they provide caregiving services. If so, if they provided those services within the last 12 months. However, the good news is in terms of collecting burdens data, CHIS 2023 did ask about burdens. In 2024 we'll ask about burdens, and those data will be available in October 2024 and 2025 respectively. And something also I want to point out is we had a really good conversation with the workforce work group a couple of weeks ago, and we discussed the option of using the California Caregiver Resource Center data to inform this measure. So looking forward to that as a possibility, maybe including some of those data as part of this dashboard next time we meet. The Caregiver Resource Center provides important services to caregivers, and they also collect rich data to their CareNav system. And so burden-related data is collected through that process, really promising. So hopefully next meeting we'll have some of those data to share as well. But we did create a dashboard based on our current available data, and I'm going to share that with you all. So I'll go over to that. So this is the caregiver burden dashboard. And the indicator here is the percent of adult caregivers, who experience financial stress, physical behavioral health issues, or a change in job status as a result of their caregiving. So folks looked at either one of these, they're included in this percentage here. And so we only have 2 years of data. So the baseline is 67.7% in 2019, and then it decreases 63.8% in 2020. That's where the status is getting better, improving. However, it's only 2 years of data, so I'm not sure how much we can glean from that. And the equity index shows some highlights there. If we look at age, for example, it looks like, as folks get older and they provide caregiving services, the burdens do increase. If we look at race as well, it looks like American Indian, Alaska Natives have the highest burdens, followed by Black Californians. So we have that data available. We don't currently have sub-state level data for this measure. And hopefully at the next meeting, we'll have regional data to share, but currently it's a statewide data. And the same thing here, the potential drivers is blank, and love to hear your feedback on what drivers we should include in terms of caregiver burdens, which we should be tracking. So again, I'll just pause here and open it up for comment. Go ahead, Heather.
Some of the drivers we should be considering are the availability of supports, whether it's family and friend support networks, as well as other types of supports. Policies that support family caregiving, such as family medical leave and employer policies to allow for people to be able to care. I think income and some of the data we've seen with the CCRCs, income and rurality are big effects as well. And I think the people who are in more rural communities often have less access to types of service supports that can enable them to continue care.
Thanks, Heather. I'm interested in the policies. That's interesting. But it might be a challenge to track that data over time. So as a work group, maybe we could kind of flesh that out. And how do we display that on the data dashboard for aging? Thank you for your feedback. Anyone else have thoughts on this measure? Anyone from the work group, maybe?
Yeah, hi, Ross. I wonder if association like the Public Authority Association that's been trying to work on data would have some data on turnover and why people come and go. I think HCI has a big contract now, and Cal Groves had a big contract in caregiving. They may have some data from why people joined, why they stopped.
Thanks, Steve. And so this is for the family and friends caregivers. So I think
Right.
that's
Okay. They do have that. That's about 20% of both of those contracts are family.
Okay, thanks. All right, so we can move on to our final measure, and that is around increasing the provider population ratio for the direct care workforce. So the work group has met about this several times and originally focused on turnover rates. However, we pivoted slightly and thought tracking a provider to older adult ratio is more actionable based on the actual data. So we worked with our colleagues at HCI to explore supply side data. So HCI has certification data on home health aides, certified nursing assistants. Of course, only a fraction of CNAs work in in-home settings, and that's our focus here. So there's also a gap with personal care aides. We also explored census micro data, and the micro data includes data on home health aides, personal care aides, as well as certified nursing assistants. So the work group's recommending to utilize the micro data as our input as we develop this dashboard. So we'll track a provider to older adult ratio. Essentially, we want to be able to track that regionally and better understand statewide supply and then also the regional level. So I have one last dashboard to share with you, and this is the provider population direct care workforce dashboard. And so these are the number of older adults per direct care worker. And we have data from 2018 to 2022. The baseline is 18.9. It went up marginally to 19.9. That's where the status is little or no change. And something, it's loading up here. There we go. So something else I should have pointed out is for all these dashboards, we have the historical data on this drop down here. So for this one, it goes back to 2018, and we have it for all the different dashboards. So something else I'd like to hear from the partnership is we currently don't have demographic data on this dashboard. I'm curious what demographic data would be helpful for this respective dashboard, which should be tracking in terms of the equity index, and of course the potential drivers as well. Love to hear about that. And some context here about the CNAs. We took about 6% of the CNAs and included them. That's the BLS estimates that about 6% of CNAs working in home settings. So that kind of makes up the ratio here. And also the geography here is based on public use micro data areas. That's what the census develops. These are a collection of counties, I believe. They don't overlap. They include at least 100,000 folks within each area. So if you hover over the respective geographies, you can get the rate by the PUMA, the public use micro data area. And so, for example, look at Napa, it's 55 older adults per direct care worker. That's in the higher end. If you go to Imperial County, it's only 7.4. So we have that flexibility there as well. So I'll pause here and open it up. Love to hear about what we should include in the equity index and also the potential drivers. Go ahead, Heather.
Again, I would say economic drivers are really important. When a healthcare worker can get a fast food job at a higher rate, that's a big decision for them to make. So I would definitely look at prevailing wages and minimum wages in those areas as a major driver.
Thanks, Heather. Go ahead, Zia.
Yeah, and similar to what Heather said, I think if you wanted to look at variation in racial, from a racial perspective, it would not be the race of the providers, but the predominant race of that county or that area. So do we see that in predominantly white neighborhoods or zip codes? There are more caregivers available than in predominantly African American.
I love that, Zia. We're kind of struggling with that, right? Because the provider race ethnicity, I don't know if it matters as much. So for the folks receiving services, right? That's what you're getting at. And maybe including that on the equity index. Good thought.
Agree.
Thanks. Anything else? Okay. Well, thank you all. I'm going to stop sharing now. And I appreciate your feedback. That was extremely helpful. And we're going to, so the next steps on this is I think target setting with the work groups. That's going to be critical in our next meeting, the next CADR meeting coming up in May. Hopefully we'll have some targets to share with the group and get your feedback there, and these dashboards will be further fleshed out. So thank you. And I think we can move on to the next agenda item. And so we're going to move to learn about the Research and Data Hub. And I'm happy to hand it over to our colleagues from the Center for Data Insights and Innovation. And that's kind of Elizabeth who will present on this agenda item. And I think, Elizabeth, you're going to share your screen?
Yes, but I was going to let Neshka introduce herself first.
Elizabeth, and thanks, Ross. And thank you, everybody, for having us here today. I'm really, really excited to share what we've been up to. My name is Agnieszka Rykaczewska. I go by Neshka, and I am the new Deputy Director of Insights Lab within the Center of Data Insights and Innovation here at CalHHS. I am very new to this role. I think I can officially say it's been about 2.5 months and new to state service. So it's all new. I'm still learning all the acronyms. So bear with me. But I'm really, really excited about the Insights Lab within CDII because really CDII is charged with creating a person-centered data ecosystem at CalHHS, which sounds great, but what does it really mean? And in my mind, what it means is that we have a ton of data within CalHHS, but it tends to live in silos. It doesn't talk to each other. And so we're limited on the types of insights that we can really see. They tend to be limited to the program. They tend to be program specific. But what about the fact that individuals are served by multiple programs and looking at them more holistically in terms of their needs? And so that's really what the Insights Lab is driving towards, is to merge together all of these different data sets and create an ecosystem within CalHHS that allows us to look across programs and really focus on the individual holistically. Elizabeth will be sharing one really exciting effort that that is an example of this type of work related to homelessness today. Now, a little bit of background on me. So like I said, I'm new to the Center for Data Insights and Innovation. I am by training an applied researcher and program evaluator. I have about a decade of various programs from education, social services, behavioral health, just about any type of program that's out there to help people. I've probably done an evaluation of one. And so most recently, I was working with First 5 LA, which is an early childhood focused commission in LA County, really looking at how do we use data and what's the most critical data that we need to be tracking. And that really summarizes my approach to data. I really don't want to track data for data's sake, do studies for study's sake that are just going to sit on a shelf. My focus is how do we get to the most critical insights that are really going to create change? And along the way, what do we need to do to make sure that those insights get used and really applied once we have new knowledge to offer so that we can really improve services for Californians. So that's a little bit about me. I wanted to introduce myself. I'm really, really excited about this partnership. Ross got to tell me a little bit about what you've already done, and it's just such an exciting piece. I think for me with the Insights Lab, there's the ecosystem part of it, but I think as part of that ecosystem, one of the pieces that I really want to bring into the conversation is creating communities of practice with researchers, really bringing the expertise of our research communities into this work as well, so that we've got all of the data that CalHHS has paired with the expertise and knowledge and work that researchers are doing outside of CalHHS. And I think between putting all of those ingredients together will create something truly magical. So without further ado, I do want to hand it off to Elizabeth to share about this homelessness effort, because I think it really truly demonstrates what we're trying to do and what we're trying to work towards with the Insights Lab. So I'll take any questions, but if there's no questions, I'm going to hand it off to Elizabeth. All right, Elizabeth, take it away.
Thanks, Neshka. And hello, everyone. And I just want to start by saying I'm so happy to have Neshka with us leading the Insights Lab. She is an amazing value add to CDII, and it is so wonderful to have her in this group with you all. So really looking forward to seeing what comes of these collaborations. I'm going to go ahead and share my screen. I will be talking today about an effort to integrate homelessness data across CalHHS and with HDIS data. So Ross was so happy to have your presentation earlier and just have that background for this conversation as well. All right. Can you see my screen?
Yes, looks
Yes.
great.
Awesome. Oh, and I'm going to also go off video while I'm presenting. My bandwidth doesn't seem to like the two of those together. So, so we are here to talk today about the latest use case for the Agency Data Hub, which is homelessness data integration and an agency level digital data product. So the need there, I mean, there's a lot of needs, but in the first setting of this use case, what we're doing is we're creating a BUCP, or a data sharing agreement, between CalICH, which holds that homelessness HDIS data, as well as with CDII and CalHHS departments. And there is a slightly different need at the department level and the agency level, but they really do complement and cross over in really great ways. So at the department level, there's a need to be able to assess and evaluate their homelessness and safety net programs, the effectiveness, the design, and so forth, and also measure housing instability and identify who is or isn't receiving their services within their programs and their departments. And at the agency level, we want to do many of these same analyses, but at a holistic CalHHS level. We want to be able to understand the interplay between CalHHS services and homelessness trends. Who is receiving services from which programs, and what happens to those folks, to be able to understand their outcomes and really kind of walk through their experiences. You know, what are the journeys that a person takes through homelessness and through CalHHS? So you can see the complementary nature between the department level and agency level use cases. And so we'll talk more about those next. So the how, like Neshka just said, we're looking to link currently siloed data sets. This is anything having to do with homelessness data, whether it's specific to a homelessness program or series of services like the HDIS, or whether it's population data, whether it is count data. We want to take
Elizabeth,
these.
sorry to hop in the middle. I'm sorry. I think
No,
folks are having
please.
some issues with the volume. If you could just possibly turn the volume up a bit. Sorry to interrupt you.
Thank you. No, thank you for that. Is that a little bit better?
For me, it is. I think, yeah.
That is perfect. Thank you, Elizabeth. That's perfect volume.
I appreciate you saying something. Thank you. So we're going to be linking different data sets together currently siloed. We're going to leverage supplemental data sets. We're going to be creating integrated data sets that will help us give a fuller picture of what's going on, and also build an agile digital data product for agency level use cases. And of course, collaboration is key. So agency and department collaboration will really be critical for aligning our homelessness efforts and analyses, for aligning our storytelling and understanding, and to leverage our respective efforts. I mean, we definitely don't want to be doing duplicative work. We don't want to be coming up with seemingly conflicting findings. We really want to be working together and tying all of our efforts together. In terms of what data will be integrated, we have a starting point right now with the CalICH HCIS statewide data. We're also going to be looking at the point in time homelessness counts to start getting an understanding of how many folks are experiencing homelessness. And the first BUCP is with two departments, with the Department of Healthcare Services and the Department of Social Services. We'll be pulling in Medi-Cal data, CalFresh data, CalSAWS, CalWorks, and other data sets that are specific to housing and homeless programs. But this is really just the starting point. The BUCPs or data sharing agreements are a good lift. So what we're doing is an iterative approach where we're getting started with the first couple of CalHHS departments, and then we'll be doing amendments to incorporate additional CalHHS departments. We are thinking about pulling in data from the Department of State Hospitals, looking at their patient release data and seeing about that transition from having institutional care to independent living, and seeing what the triggers and correlations might be around homelessness there. We'll be pulling data from the Department of Rehabilitation, who provides vocational rehabilitation services for individuals with disabilities, and seeing overlays with those services and individuals who are homeless. Also looking with, working with HCI for hospitalization data, with CDPH for, with their CalReady data, which looks at infectious diseases, death data, women, infants, and children data. And then DHCS and CDPH both have really great behavioral health data that we can pull in. And so just doing a landscape assessment of starting to get a sense of what different kinds of data sets do we have that we can pull together and start integrating and linking. We're also interested in future explorations outside of CalHHS to be seeing what we can work with the Department of Education, with Corrections and Rehabilitation, and with Veterans Affairs. For the agency level product, there's a question about what will this data product be like? We're not going to be building a dashboard. So a big part of the need is for executive leadership at the agency level, but also the department level, to be able to ask a question and get an answer. So we're looking to build an agile data analysis and visualization tool that would be really navigated by experts, by analysts, by subject matter experts, and that would produce reports and visualizations and summaries based on the questions and needs of executive leadership. So a different type of data product, but one that enables us to interface relatively quickly and easily with this data coming in from all these different sources. We have so many use cases around homelessness and so many questions to answer. One of the things we're looking at is, what should we answer first? And the very, very first place we're going to be going is to to look at how many people are homeless according to what sources. So what we know right now is that there's some pretty big variation in different sources' estimates of California's homeless populations. So let's look at what those counts are, what those sources are, and where we might get to the best estimate we can with the data that we have. We want to have a general sense of where these folks are living and what services they're receiving across CalHHS. And then it starts looking at the focus back to experiences and outcomes. So this is going back to holistically analyzing the interplay between our services and homelessness trends, understanding those outcomes of the collective service provision, and then again back to that person's journey. And so many, many questions to answer, but all focused in these general areas. And of course, sharing is caring. So we want to just really call out all ideas are welcome. We want to collaborate with departments. We want to collaborate with stakeholders. We really want to hear about other people's ideas for what data sets we should be considering pulling in. What other questions could we ask? What are other visions for compiling and analyzing homelessness data? And then who else to include? Who wants or needs to study homelessness data? Who might be able to leverage the data assets that we're producing during product development? So one of the things that CDII will be doing as we move forward with product development is creating an integrated homelessness data set that looks at data from HDIS, as well as data from other sources of homelessness counts, as well as program participation data, as well as CalHHS program data, where there's an indicator of homelessness, but that when that person is not in the statewide HDIS data set. So we really want to start pulling together all of these different sources to have this robust integrated data set that gets regularly updated. And always, of course, acknowledging privacy and legal authority, we want to share. So really looking forward to collaborations and conversations with you and with CalHHS overall. And stop sharing. Any questions?
Elizabeth, wow, this is phenomenal. I'm just blown away. I'm kind of speechless right now. I'm just thinking about the homelessness measure that we're working on that I presented on. What a great input, and like linking these administrative data sets. That's so critical, and I wish the state actually did that more. So thank you so much. And then I just want to say that before we open up for questions. And I see Bella has her hand up.
I know I keep saying this, but this is so exciting. Thank you for an amazing presentation. And, one of the things, we've really been talking about in our committee is that we haven't been able to do causal inference because we just don't have the data. And what you just presented would allow us to do the research we've been wanting to do for a decade. So all I have to say is we're incredibly excited. I mean, I think for any individual question, if you're looking at, what is the effect of, intervention A on outcome B, the particular variables you'd need for that, would come up in that project. But what you presented looked good enough to do most of what we want to do. And my only question is, when can we get started? This is amazing, exciting, and will be transformative. It'll let us do really good research. So thank you.
Thank you so much, Bella. That's really awesome to hear and really exciting. The when is such a great question. So I'm gonna say this just really candidly. It is a challenging thing to put together a BUCP data sharing agreement across departments. It takes time.
I know.
Yep.
That's why it's such a big deal.
It's such a big deal. But we're at a really good spot. We have been chugging along. So we're not sharing this presentation at the very start of the efforts. Let's see, we're about the 3/4 way through. So we're really, really hopeful that we will have the data sharing agreement in place before the end of the
short a meeting, especially when it's.
I'm sorry, before the end of what?
The current fiscal year. So,
Okay, and that for you guys is August
will,
or?
oh, I'm sorry.
Could you please mute whoever's unmuted? Panel members, just please be unmuted. Thank you.
And the current fiscal year for the state is June 30th.
Okay.
So
wonderful.
yeah.
Great. Thank you.
Absolutely.
Other questions from panel members? I don't see any hands. Thank you so much. Oh, go ahead. I'm sorry.
I'll jump in if I can take just a couple of seconds, because one of the things that I'm in the very, very early stages of thinking about is, once we have Elizabeth's data set in place, we're going to start chugging at the analyses, right? But that gives us numbers. It doesn't give us the story. And one of the things that I'm thinking about is how do we create a community where we can bring those numbers to folks with lived experience, with folks who have been researching these topics for ages and ages, and they have all the expertise, with policymakers, with a very diverse group of people to really take a look at these numbers and understand what might be going on here, and how can we really understand beyond just numbers, beyond just trends, what the story might be, what other questions we need to ask, what kinds of recommendations might be made based off of what we're seeing. And just kind of wanted to note that here, because I'm probably going to be coming at some point to this group to say, would anybody be interested? Because I really, one of the things that's really important to me is, as we tell that story, and Elizabeth noted, we're really wanting to align not just on the data work that we're doing, but also aligning on the storytelling piece of it. And I really want that to be grounded with those that have various types of expertise related to these issues. So just kind of also wanted to create that kind of shout out. I am said at the very early stages of thinking about this, so I have no details about when or how or what it's going to look like or how I'm going to make it happen. I just wanted to call out that that's another really important piece for me.
Thanks, Neska. We appreciate that. And I think the partnership is really interested in this work. So we're definitely here.
Thank you.
I don't see any other hands, so thank you so much. That was really interesting. Look forward to collaborating going forward. So we can move on to the last agenda item, and I could kick things off. And I'm excited about this agenda item because this is about collaboration. And so the purpose of this, when I pull up the slides here. And so the purpose of this final agenda item is for the partnership to agree on a common set of goals and priorities. And I'm hoping that we can come back to this goals and priorities discussion maybe every meeting. And also it's an opportunity for folks in the partnership to present on ideas for collaboration. Just waiting for the slides to pop up. But I sent out a goals and priorities document maybe a couple of weeks ago, and that's gonna spur this conversation. So for today, in this agenda item, myself, Angie, and Zia will present in some of our efforts and welcome your feedback and opportunities to work with us. So go back one slide, please. Thank you. And so also the purpose of this exercise is to plan for the upcoming day of action. So our last day of action was September 2022. That was before my time. I joined CDII in December, but I know a lot of you came to the 2022 day of action. And I think for the research partnership, Zia and David in particular, they presented on the partnership and our plans over the next couple of years. And so now we have our next day of action coming up. And the purpose of this day of action, similar, is to gather recommendations and provide updates on some of the priority work of the partnership. And so we have 3 partnership meetings, including this one before the day of action. So I'm hoping we could use these meetings to prioritize what we like to present at the day of action. So the day of action's on Tuesday, October 8th. It's going to be in downtown Sacramento at the Convention Center, times TBD, but please, we would love to have you there. So mark it on your calendar. And so I'm hoping, you can go to the next slide, please. To help prioritize what we're going to present at the day of action, we developed a draft of different topics we feel are important. And this is not an exhaustive list. It's also fluid because based on your feedback, it's probably going to change. And we obviously can't present everything. So we're kind of focusing the scope of this list during these meetings. So let's want to point out a couple of highlights. I think championing the need to link administrative data. That's the 4th row. And this perfect segue, based on the last presentation we had. That's critical, right? And we know the important insights we can gain when we link to these administrative data. There's a couple of topics related to behavioral health that West Health is leading in some of those efforts, and Zia will discuss that here in a few minutes. Advanced data collection of the direct care workforce and the family and friends caregivers, that's really critical, especially as we move along the outcomes process. And the last struggle is about collecting data about the experiences and needs of the older adult LGBTQIA community, and myself and Angie will speak to some of that work. So we'll probably have time, I'm not sure, but if other partnership members want to share some of the work that they're involved in, please feel free. If not, you can think about it for the next partnership meeting. Go to the next slide, please. So with that, I'd like to move us along and provide you with an update on a survey that some of you have probably heard about, and that's our older adult LGBTQIA+ survey. Really excited to announce that it's live as of January 8th. And this in background, this effort came about because the state's never collected data on the older adult LGBTQIA community. And all the work that we undertake is grounded with equity and lifting up underserved communities, but without data, we don't fully understand the needs and the experiences of the community. And we are also allocating resources as accurately as we could be. And that's why this survey is so important, and why we're excited to get this out in the field. So CDII is proud to support this effort, and we're working with a great team. We partnered with the Citrus team at UC Berkeley, Open House in San Francisco, and a really talented research team at UCSF. So Open House has led efforts to ensure that we work closely with the community. They've been a great partner, as has the Citrus team, has really kept this project on track. They've been great collaborators and project managers on this effort. The research team at UCSF that we're working with, these are the folks that administer the PRIDE study, if you're familiar with that. Talented, very talented team. They're very well versed in survey design. They also present data in a very easy to understand manner. We thought that was really important. So this round of the survey is to collect baseline data. Our hope is that CDII and one of our partners can administer the survey periodically going forward, so we can build upon this baseline data set and really understand how needs are shifting. And the overarching goal is that these data inform policy and inform policymakers, healthcare providers and advocates and others, and how to improve healthcare access and quality for the older adult LGBTQIA community. Because we know based on previous research that the LGBTQ community, they face barriers in terms of accessing healthcare, receiving timely care, not having a usual source of care, and experiencing unfair treatment. So we hope that these data can help lead to improvements, expansion of training across healthcare networks, improved access to LGBTQ affirming medical and social service providers, and the development of programs based on the needs of the community. And this survey also advances the goals of the NPA. So the survey touches on several goal topics in the NPA, but it really gets to equity, which is what the NPA is grounded in. Go to the next slide, please. So this slide shows a timeline of the study. And so we're past the planning phase and this survey refinement phase. Happy to announce we launched the survey on January 8th, so it's live right now. We'll conduct analysis of the survey data in spring, and then we'll have outputs to share in early summer. You can go to the next slide, please. So I mentioned that Open House was instrumental in ensuring that we work closely with the community on this effort. And so the Open House led efforts to develop a statewide coalition. And so the study team, we partnered with that coalition. We're leaning on them heavily to help promote the survey. And the coalition's comprised of 52 organizations throughout the state. And these are LGBTQ centers, area agencies on aging, healthcare providers, community centers, et cetera. And we have representation all throughout California. So LA, other parts of Southern California, Central California, the Bay Area, Sacramento as well. And a subset of that coalition served as the survey advisory group. And so the research team met with the survey advisory group several times as we developed the actual survey instrument. They provided valuable feedback on what questions to include, what not to include, possibly response options, et cetera. And we also understood that it was critical to gain the trust of the community to really garner a high response rate. And I think in partnership with the Open House, we made we made progress in that regard. Go to the next slide, please. So I want to share some high-level information about survey methodology, and the survey domains include economic and social well-being, behavioral health, and physical health. We'll, of course, collect demographic data from survey respondents as well. So wide-ranging surveys, we estimate that will take about 20 to 25 minutes to complete. To qualify to take this survey, one must identify as a member of the LGBTQIA community, be at least 50 years of age, and be a California resident. This survey will be available in Tagalog, Spanish, Chinese, and English. And there's going to be an emphasis to oversample the BIPOC community, because we want to make sure that we collect enough data that it's significant. And the research team at UCSF, they employ best practices, and they have a lot of experience in survey design. It's really proud of the survey. And then my final slide, if you could just move forward one slide, is a humble ask to you. I think it'd be really helpful if the partnership can please help promote this survey. We would like to reach every community and region in the state and every type of community, rural, frontier, urban. I have some promotional materials I can send out to the partnership. It's as easy as scanning the code on the slide here. And also CDII is hosting the webpage for the survey. The link is on the slide as well, and I'll place the link in the chat. Sorry to kind of rush through that, but we're kind of running short on time. So with that, I want to hand it over to David. So David and Angie are going to speak to some further efforts with the LGBTQ effort, I guess, and some focus groups. So David, I'll hand it over to you.
Thank you, Ross. And I'll keep my comments short to turn it over to our colleague, Angie Perrone, who we're thrilled is the project lead for conducting the next phase, a supplemental phase. But I do have to call out three specific thank yous. First, to the department for championing this area. It has been fabulous to have the support, the opportunity to create this statewide survey, which will be a national model and is already having fantastic results. In the first week, we received 650 responses, and with this vast promotion now, we hope to rapidly expand not only to those who are easily accessible, but those across the state. Second, it's been just a fabulous collaboration of our Citrus team with UC Berkeley, UC SF, and Open House, who are just great partners in this area. And we have to thank Marcy Edelman from our California Commission on Aging, who got us started here. And finally, and this leads to what we're excited to share with you today, that through the support of 3 additional foundations, this California Healthcare Foundation, the Meta Fund, and the SCAN Foundation, we're now able to do a deeper dive in focus groups. And this will help us get to all areas of the state, really look at population subgroups that have not been ever really identified or had input into our process and our needs for this very impacted population. So with that, I'd like to just turn it over to Angie Perrone, assistant professor at Berkeley, who is going to lead this effort for the next year. So with that, Angie, please take it away.
Great. Thanks so much, David. We can move to the next slide if that's okay. Great. So we just wanted to explain a little bit about the research methodology. You heard about the survey already. So for the focus groups, we're going to be using an explanatory sequential design, using an equitable aging framework, theoretical framework. And so we're fortunate to have the surveys going to produce all sorts of great information and data. So we'll be able to use that to help contextualize some of the survey responses, provide some use it sort of to provide some explanation to, and to really dive into the nuances of some of the disparities that we're anticipating to find, and also potential sources for support and opportunities for interventions and prevention as well. And so we're targeting 10 to 14 focus groups throughout the state of California, although we're hoping to do at the sort of the higher end, although it depends on what we end up, how the groups sort of emerge. Also aiming for 80 to 100 LGBTQ plus older adults, 50 years and older, so midlife and older adult. And then we're going to be doing recruitment via survey through the survey that you just heard about, and then community partners. And so we have a question at the end of the survey that asks participants if they're interested in engaging in additional research. And so that will be a way to we're going to use that to identify potential participants for the focus groups based on particular groups that we're targeting. And we're going to be really targeting the hardest to reach, the communities, LGBTQ plus communities, older adult communities that have been less visible, are sort of smaller in number. And so we may not be able to do sort of certain types of statistical analyses based on the smallness of the population or the sample itself, but they're a sample or a community that perhaps has elevated needs, and targeted interventions are needed because of intersections of race and gender and lived experiences of discrimination, as well as coping, and all sorts of strategies that may inform really interesting and creative interventions and needed interventions too. So that's sort of a little overview. And then also recruitment, we're going to be recruiting through our fantastic community partner network. Next slide, please. And then, oh, something happened with the formatting here, but apologies on that. But why focus groups as opposed to other types of methods or approaches? So again, we want to use focus groups to help contextualize the community needs and explain disparities revealed in the survey. And then focus groups are especially helpful when you want to explore complex phenomena and needs in communities that are experiencing multiple forms of oppression that are difficult to study solely from survey data. So example here would be Black transgender older adults, can also include income, low income participants as well. And then we anticipate that because of historical experiences of discrimination and stigma, that there will be some common experiences that will help form the bedrock of these focus groups, but that there will be differences that we can explore and nuances that will, again, help sort of identify really robust interventions for these sort of subpopulations or subgroups and communities that that we really need to sort of focus on in targeted interventions. And then, of course, focus groups also allow participants to bounce off ideas, diversify opinions, and flesh out ideas more comprehensively, which will help us really identify. So this, I think this also is nice dovetail off of the previous presentation of sort of getting the lived experiences from people who are actually, living living the data as it is. So again, we think that this will surface promising opportunities for community-based interventions, resources, and supports. Next slide, please. And then this is the timeline. We're starting this now. It's going to overlap, of course, with the survey. And then we'll be doing we anticipate doing most of our focus groups over the summer, although we might have some that we do a little bit in the fall. And then we'll be doing our data dissemination through, mostly through the fall or Q4. Next slide, please. And then I wanted to share this in terms of final products that we're anticipating that we think hopefully will be beneficial for lots of stakeholders, lots of folks in California, but maybe of particular interest to this group as well. So we'll do, of course, this sort of summary in the final report, but we're also intending to do some one-page FAQs and handouts with infographics. We're looking at doing some videos and case studies, and then we'll have a public slide deck that will share information about what we've learned from this particular part of the project. And then next slide, please. And then again, just sort of emphasizing what David had mentioned is that we're fortunate to have, and while we're still finalizing the funding, we're fortunate to have support from the California Healthcare Foundation, MetaFund, and the SCAN Foundation. And of course, the California Department of Aging and all of the amazing community partners that have been foundational and critical to making this project happen. So happy to answer any questions, but very excited to have the support and looking forward to getting this much needed information and to share it with everyone here.
Thanks, Angie. So we'll pause here before we hand it over to Zia. So does anyone have questions on the survey or the focus groups? Okay, let's see. Jasmine, go ahead.
Hi, thank you so much for the presentation. This is really exciting to be able to hear of all of this that's coming about. I think it's long overdue and really a need to focus on the LGBTQIA communities. My question is, could you provide some examples of the focus groups that you're planning to host, and the different regions or different race, ethnicity, backgrounds that you'll be including?
Yeah, great question. And so part of that is still being informed with conversations with some of our funders, but we anticipate doing focus groups both based regionally. And so we'll have a couple of focus groups in Southern California, and we have identified community partners that we're going to be working with. They haven't been publicly identified, so I can't share those quite yet, but we have 2 community partners in Southern California we're very likely going to be working with, sort of in LA, in the San Diego area. We're also going to be working with community partners in the central, sort of like Chico, sort of central California area. We have community partners we're working with in the sort of upper northern region, so sort of thinking like Redding, Eureka sort of area. And then we have sort of the regional place, which we anticipate will help us identify the various needs based on place and location, and also help us identify geographically isolated participants. And then we'll also be focusing, organizing some of the focus groups specifically around positionalities like race and gender and the intersections thereof, targeting communities that are particularly more invisible and in a lot of the sort of resources and tools and research and interventions and approaches to interventions. So we've identified several communities in particular. So Black, low income. We also have linguistic support, so we can do some focus groups in Spanish and Cantonese. We also have some additional linguistic potential focus groups that we're exploring, and part of that will depend on the interest in the focus group through the recruitment process. And then we're going to also be sort of, and again, these are the intersections, looking at focus group participants, specifically low income participants as well. And so we have this approach that's also going to be sort of a hybrid of both in-person and hybrid, knowing that there are strengths and weaknesses to both and benefits and challenges to both, to target the hardest to reach in a variety of different ways. And so part of that approach is going to be determined, again, as we continue to work with our community partners over the course of the next few months to determine which regions and which populations make sense to do in person and which makes sense to do sort of in kind of a hybrid format or like a more sort of remote format.
That sounds great. Thanks, Angie.
Sure.
Any other questions? Okay, I'm not seeing any hands, so I'll hand it over to Zia, and then if we could pull the slides back up, please. Thanks, Zia.
Can you hear me, Ross?
Yes.
Thank you so much. Boy, I am completely blown away by today's presenters and presentations. If we were to create a greatest hits album, we have 3 from Angie, Michael, and Elizabeth today. So I don't know how I will do now, but I will try to keep it short and brief and leave it open for more discussion from our group. But Ross had asked me to provide an update on some of the work that we are doing in partnership with CDII and the MPA collaborative around behavioral health. If you can go to the next slide, please. So in our work on defining the key outcomes and drivers, we were also simultaneously as a group and as our work group and the larger group have been looking at opportunities to identify gaps that can be sort of researched and sort of start to build this body of work to really inform some of the things that we're talking about in the slides today in terms of what are some of the drivers for behavioral health and are there access issues, are there other sort of pain points from a population perspective. So to that, we've sort of done 2 aligned efforts that I'm really excited to share about. They're both sort of, I can't share the full results today of both of these, but we will be sending out more information in the coming weeks to all of you. So we engaged with a group called Whalen Research, I guess in November last year, and with our partners on this call. And I really want to thank CDA and Sarah and Susan and Ross and Terry for helping us develop this survey and launch this survey. It was in the field November, the second week of November, and we just got the top line results. And it's essentially a survey of older adults in California, really a public opinion poll of what are the impacts of behavioral health and what are some of the needs. And then the second thing I will talk about is the other side of the coin, which is really looking at the delivery system and what are some of the pain points and opportunities for improving how care is delivered, and that we are hoping to do through a all payers claims analysis. Next slide, please. So a little bit about the survey. The survey was designed and launched in California for adults 65 and older. We had a sample of 1,500 respondents, which we did achieve. It was conducted in 4 of our sort of most common languages: English, Spanish, Cantonese, and Vietnamese. And we really sort of took an approach to address topics that included both sort of the self-assessed needs of the population. And I think some of the data here will confirm and dig a little deeper on the data that we saw from CHIS. We wanted to really study the impact of behavioral health issues on lives, sort of the lived experience. We need to look at affordability and access, and then what are some of the most common barriers to getting access to treatment. And then, coming out of COVID and with the sort of use of technology, we wanted to also see what is the interest at the population level to receive care remotely. I think remote modalities really help in some ways level the playing field and reduce access barriers in rural and far to reach communities. And then we also wanted to have the respondents compare and contrast their experience of receiving physical care and mental health care. And it's important because there's both policy work happening around parity issues, i.e., should payers be treating behavioral health similar to physical health? And I think there's also issues around providers, and then ultimately stigma around behavioral health and how people themselves differentiate their behavioral health needs from physical health needs. We will have the results by late January all written up, and we'll be happy to share those with all of you. Can you go to the next slide, please? So here are some, I would say, some of the top level findings that we are sort of assimilating right now. We saw from the CHIS data, approximately 5% responded to be moderate to severely depressed. In this survey, 10%, because this includes not just the moderate to severe, but any symptoms of depression or social isolation. We also saw that 1 in 4 Californians reported having feelings of sadness, stress, worry, and their inability to enjoy life, which is a very high number, I would say. And then if you think about how they believe that mental health services in the US are meeting their needs, almost half felt that mental health care is not affordable, and we need to do a better job of making it more affordable to them and making it more accessible. And then on a positive note, almost 2 in 3 responded that they would be open to accessing healthcare in a virtual modality. And this is important because there's the perception that older adults are unlikely to use technology, and I think that's a ageism or a bias that we should very quickly dispel. That the vast majority of people are able, and if provided the right resources, of course, there are gaps in access to technology in these populations. Next slide, please. And then on the other side of the coin, really to try to understand, we have the population level data and its impact, but then how do we fill in the gap on understanding, what are the patterns of care today and where people are accessing care? And I'm so excited by the California All Payers Claim database that is going to come online, which really is even a more richer resource than what we have access to today. We are working with a company called IntelliMed that has all payers claims data for the nation. We had got access to that in the 4th quarter of last year. And it has, similar to the California data, it has inpatient, outpatient data. It does not have pharmaceutical data, which I saw that the California data does have. And then you have the ability to use this data to assess patterns of care. While the patient is de-identified to us, they're able to provide you what they call patient journey. So you can actually follow patients or cohorts of patients longitudinally to see what happens to their care journey. You can obviously study underserved populations and access issues because the data is available by provider and zip code and county and NPI. You can look at utilization in different care settings, i.e. what type of care is being provided in the inpatient setting versus the outpatient setting or emergency room setting. And then I think this data can really help us understand where there are opportunities to have care coordination, and then how do we build towards this, what we call a continuum of care, a system of care. Many patients are receiving behavioral health services in the most acute or the most expensive care setting. And I think we need to transition some of that care to more in the outpatient setting and community-based setting so that we can prevent both those bad outcomes that happen in these acute settings, but also lower the healthcare cost. What I want to discuss today, and I don't think we'll have time today, but we can do this offline also, is like, how do we partner with all of you to start to think about how can we use this all payers claims database? And we are exploring it from behavioral health perspective right now, but I'm sure you all have ideas on how to partner with us. We have purchased seats for Ross and his team to be able to have access to this data. And I think if we can collaborate together, there are opportunities to start to leverage this in 2024, to start to ask them questions, perhaps even in preparation to then having access to the California all pairs claims data set that we heard about today. So I'll stop there. Anybody has any questions or thoughts, please either share in the chat or we have Q&A session after this.
So any questions? And I think, Zia, that's a good topic for next meeting to discuss how we can collaborate on those potential research topics. Thank you so much. So thanks, everyone. I think I'm gonna hand it back to Carol for public comment.
Hello, thank you. Thanks for that slide, Rosie. This is our public comment period. The public's invited to make comments. You may raise your hand via Zoom or *9 if you're attending by phone. I see, let's get right into it. I see Winnie Greco has had their hand up, so I will unmute you if you want to go ahead and pose your question, Winnie, or give us your public comment. Could be an old hand. Could have put the hand up earlier in the meeting, I should say. This was a very robust discussion among committee members. If there's any public comments, I'm happy to take them now. And Winnie has taken down the hand. Give it a couple more beats. We had a lot of data this morning. Okay. Well, we do want to remind you at any time, if you have a comment, you may email it to us at engage, ENGAGE at aging.ca.gov. Happy to take your written comments at any time. I'm going to turn it back to Ross to close us out.
Thank you, Carol. You can go to the next slide, please. So in terms of next steps, I mentioned the day of action coming up, and we'll use the next couple of CADR meetings to kind of plan for what we're going to present at the day of action. Also work with the respective work groups to kind of flesh the MPA key outcome measures out further and share those at the upcoming partnership meetings. If you want to go to the next slide, please. Something I wanted to share as well as we kind of wrap things up. It's a big year for CDA. This year celebrates 50 years of serving older Californians. To celebrate this anniversary, we've launched the 50 Stories, 50 Years campaign. And basically, we're sharing stories from people whose lives have been positively impacted by California's aging network of services. This includes you all, our stakeholders and partners who played a pivotal role in shaping and delivering services over the past 5 decades. So as a MPA Stakeholder Committee member, we invite you to share your story. Your experiences and insights can serve as an inspiring example of the positive impact we've had together over the years and what's to come through the collective efforts of the MPA. So if you're interested in sharing a story, you can please email CDA's communications teams, and the email is right there, communications@aging.ca.gov. And so with that, we could wrap things up. Thank you so much for your time. This is a phenomenal meeting. I appreciate everyone's feedback. Thank you so much. Have a great weekend.